Welcome to this Clinical Explainer. Today, we're diving into part 3 of our curriculum, the full spectrum of diabetes. I'm going to act as your medical coding instructor to really decode these complex classifications of diabetes mellitus. Because look, getting the diagnosis right in the clinical documentation, well, that's only half the battle. Translating it precisely into the medical record, that's where you come in.
Our agenda today breaks down into 4 actionable sections: primary classifications, pre-symptomatic type 1 stages, pancreatogenic and genetic variants, and finally, decoding your next steps.
Section 1, Primary Classifications. Let's clearly define those foundational diagnoses you absolutely need to know.
So let's start with a really critical boundary. As a coder, you've got to recognize this distinct clinical threshold. Type 2 diabetes is a chronic condition, usually in adults, right? It's defined by the body's inability to use insulin properly, which results in constant hyperglycemia. Prediabetes, on the other hand, definitely features elevated blood sugar, but it's explicitly not high enough to trigger that formal type 2 diagnosis. So when you're reviewing a chart, do not code type 2 if the provider only documented elevated blood sugar or prediabetes. That clinical boundary is absolute.
Moving on, we have the defining characteristics of type 1 diabetes and its related autoimmune forms. This is where the clinical documentation gets highly specific.
You really want to notice the spectrum of the autoimmune response here. Classic type 1 diabetes, or T1D, requires lifelong insulin. Simple enough. But look at these next 2 clinical triggers. Brittle diabetes is literally hypervolatile. And honestly, tracking down the codes for those frequent hospitalizations can feel just as volatile as the condition itself. Then we've got LADA, which stands for latent autoimmune diabetes in adults. Just like type 1, it's an autoimmune reaction, but the onset is usually in patients over the age of 30, and it develops much more slowly. Spotting these specific terms in a chart ensures you capture the exact etiology the physician is actually treating.
Section 2, pre-symptomatic type 1 stages. Let's move into the highly specific escalating progression of type 1. This disease actually advances through very identifiable asymptomatic stages long before any clinical symptoms ever emerge. For coders, this is totally vital to know because ICD-10 guidelines have specific codes like category E10.A- specifically for early-stage type 1 diabetes that predates the onset of symptoms.
Notice exactly how this escalates. I really want you to memorize this progression. Step 1 is stage 1 asymptomatic autoimmunity. Here, the patient has 2 or more islet autoantibodies, but their blood sugar, completely normal. Moving to step 2, stage 2 asymptomatic dysglycemia. The autoantibodies are still there, but now we're seeing glucose intolerance, so abnormal blood sugar. At this specific point, the 5-year risk of developing clinical symptoms jumps to roughly 75%. Then finally, step 3 is stage 3 clinical T1D. This is the onset of those overt classic symptoms like frequent urination, known clinically as polyuria, and extreme thirst or polydipsia. This stage requires lifelong insulin therapy. Accurately mapping this timeline in your coding reflects the exact severity and stage of your patient's autoimmune journey.
Section 3, pancreatogenic and genetic variants. Now let's compartmentalize the rare variants that truly separate the average coders from the experts. These rare subtypes have hyper-specific clinical indicators. When you're reading through a specialized endocrinology or OBGYN chart, these are the exact trigger words you absolutely must be hunting for.
Let's walk through these vital subtypes together. First up, type 3C diabetes. This develops specifically due to pancreatic damage, so think chronic pancreatitis, cystic fibrosis, or a pancreectomy. If a patient has their pancreas removed, well, that leads to type 3C, and you'd be looking at post-procedural codes like E89.1 alongside your diabetes codes. Next, gestational diabetes. The key timing here is an onset appearing between 24 and 28 weeks of pregnancy, which is caused by placental hormones blocking insulin. Then we have neonatal diabetes, a really rare form occurring strictly within the first 6 months of life. It can be permanent or transient, meaning it disappears within a few months but might come back later. Finally, MODY, or maturity onset diabetes of the young. This is monogenetic diabetes caused by an inherited genetic mutation, and there are over 10 different types documented. Knowing these onset timelines and physiological triggers allows you to actually query a provider if the documentation seems, contradictory.
Now, when you spot gestational diabetes in a chart, you cannot just stop at a high-level code. You've got to jump straight to subcategory O24.4. But your job isn't done there. You must look closely in the physician's notes for exactly how it's being controlled. Is it diet controlled?
Is it insulin-controlled, or maybe it's controlled by oral hypoglycemic drugs? Here's a pro tip straight from the guidelines. If the patient is treated with both diet and insulin, you only report the code for insulin-controlled. Capturing that specific therapeutic management is absolutely essential for a clean, compliant claim.
Section 4. Decoding your next steps. Let's figure out what you do next and wrap up this classification masterclass. Ultimately, perfectly charting a patient's health journey depends entirely on your ability to apply these distinct clinical definitions. Whether you're distinguishing between the asymptomatic stages of type 1, recognizing the glycemic volatility of brittle diabetes, or pinpointing the exact trimester onset of gestational diabetes, your precision really matters. It impacts patient risk adjustment scores, ensures the provider's complex medical decision-making is recognized, and most importantly, it maintains an accurate medical history for the patient. So the next time you open a complex chart, ask yourself, which hidden diagnostic subtype will you uncover in your very next chart review? Will it be a slow-moving LADA, or maybe a type 3C stemming from an underlying pancreatic condition? Keep your eyes sharp for those clinical triggers. Like, share, and subscribe to Decode Healthcare with Harshal.